See my screen. Are you able to hear me?
Yeah, Rohan, we see you.
Fabulous. And if you can see my screen.
Yeah, sure.
Perfect. So, good morning, everyone. Good morning, good afternoon, or good evening, depending on where you are in the world. Thank you so much, first of all, to LVA and APLA for giving me this opportunity. And thank you so much, Dr. Datta, for the kind introduction. I thought of picking this topic because this has not been touched before. And over the last couple of years, actually, I've been doing more head and neck than laryngology. I do have the capacity to talk on that particular topic because of my fellowship in Birmingham, as well as my current appointment as the head and neck fellow at the Cambridge University Hospitals. So let's first quickly go through the anatomy. So there are two nerves supplying the larynx, superior laryngeal nerve and the recurrent laryngeal nerve. The recurrent laryngeal nerve is divided into two branches, anterior and the posterior. The branching point is located either inside the larynx or before the nerve enters the larynx. Now, this posterior branch it projects superiorly to form the anastomosis of Galen with the internal branch of the superior laryngeal nerve. And the anterior branch, it carries motor fibers to the posterior thyroid muscle, the lateral cricoretinoid, and the most important, that's the thyroid retinoid or the vocalis. The superior is divided into two branches, internal and the external. The internal is the one which enters the larynx, and then it carries the sensory fibers down to the level of the glottis. Whereas the smaller one, the external branch, which passes deep to the superior thyroid artery, it innervates the cricothyroid muscle. Now, this is the one which is surgically important for us. It also tends to reach the anterior glottis and tends to supply the thyroid muscle. That's the reason why it's called as a human communicating nerve. And this may be important in terms of recurrent laryngeal nerve injury and reinnervation. And this is also the reason why later on I'm going to talk about this, why the nerve monitor actually gives you a signal for the superior laryngeal nerve. This is just a diagram of the courses which we spoke about. Coming to the injuries, the surgically induced nerve injuries are most often intraneural damage inside a macroscopically intact nerve due to either pressure, crush, or heating from adjacent use of cautery or powered devices. Now, neuropraxia is the mildest form, and it's just injury to the Schwann cells, which recover by themselves in 6 to 8 weeks' time. Whereas accentomasis is the one which is the worrying bit. There is varying degree of axonal injury, which leads to death or neuronal death or dysfunctional reinnervation of the target cells. Now, this leads to poorer outcome for functional restitution. Coming to the injury, now this is debatable, 5 to 10%. It all depends on how much you check and when do you check and whether you check or not. There are multiple papers on it. But I believe around 5% is something which we should reach a consensus on. And most of them are temporary. Permanent should be less than 2%. If you're having anything more than 2%, I think so you should relook at your technique. Unilateral and bilateral. We're going to talk about unilateral only just because of the time constraint for this lecture. And it's more common in complex cases like malignancies or revision cases. Now, what are the symptoms which you're looking at? Hoarseness, dysphagia, dyspnea. Quite a few of them are asymptomatic. We just see them during a scope after surgery. And if it's a superior laryngeal nerve, then it's a loss of high pitch, which the patients complain of, often singers. Let's get the basics right first. So mastering the anatomy is the most important thing in terms of preserving the nerve. Getting some training in terms of a fellowship, training under supervision is the best way to go through the ranks. Work through simpler cases first and then reach the complex cases. And follow consistent technique and practice that consistent technique over and over again to get better at it. This is the most important thing which is going to save your nerve. Loops. There are quite a few advantages. You appreciate things better, especially the superior laryngeal nerve, the parathyroids, smaller blood vessels can get better hemostasis around the nerve. But there are some disadvantages too. It comes with a cost. There is dependence. can't operate without loops at times. And there's a restricted field of vision. You do have a blind spot around. And the learning curve, obviously, you need to get used to it. It takes around 10 to 20 cases for you to get used to your loops. Now, these are my loops over here. 2.5x, 50 centimeter working distance. Some surgeons do advocate the microscope. I've seen Dr. Satish Jain sir actually using the microscope for his thyroids. That's also an excellent technique. It's just about getting magnification in your field. There is a study, a 10-year study, which is from Italy, and they have shown that using loops for magnification reduces post-operative complications. So it's something which needs to be adopted. Coming to nerve monitors. Now, this is a NIM3 nerve monitor. The screen is on the left. The tube is on the right. You can see that the cuff has electrodes on it, which carries the signal onto the monitor. And I'll just explain you exactly how it happens. The intraoperative nerve monitoring of recurrent laryngeal nerve is performed by stimulating the peripheral nerve directly with an electrical current. And then there is a subsequent recording of the muscle depolarization of the thyroid retinoid. Now, this muscle action potential is utilized as an indirect measure during the surgery. And thyroid retinoid depolarization is recorded through electrodes, surface electrodes on the ventilation tube, as we saw earlier. Now, absence of the action potential means injury could be anywhere along the nerve, but it's always distal to the site of stimulation. Now, there are certain advantages to using the nerve monitor. It's reassuring to get a signal. It's good in medico-legal cases that you got the signal. It's good for training surgeons. And there are certain disadvantages too, like the cost. The anesthetist also needs to be trained for a larger tube, and no muscle relaxant needs to be used during the anesthesia. And device malfunction, like false positives and false negatives associated with it. Now, this is a very busy slide showing what the NICE guidelines were published in 2008. At the end of it, I think so it's very ambiguous, saying that I'm not really sure whether we need to use the nerve monitor or not. However, there have been a few meta-analyses, and this is the best one, which is done from Taiwan, published in 2018. Now, this shows that the intraoperative nerve monitoring, it can definitely reduce the incidence of total, transient, as well as permanent recurrent laryngeal nerve injury compared with the conventional visual identification which was followed. We also recommend intraoperative nerve monitoring in bilateral operations and malignancy operations, is what they said. But what I found was this article from Tata, which was published in 2019 from Prathamesh Pai and Devendra Chaukar. It has summed up the nerve monitoring the best. Evolution of intraoperative nerve monitoring, they call it as a paradigm shift. Uniform guidelines need to be set up, and they can significantly reduce the vocal cord palsy rate and guide intraoperative decision making. While there is a lack of consensus regarding its benefit in routine cases, its high negative predictive value has shown definite advantage in high-risk procedures. As far as my opinion is concerned, I do tend to use a nerve monitor, and I have found it to be of benefit during complex procedures at least. Coming to the next point, steroids. Preoperative steroids do not appear to reduce the risk of recurrent laryngeal nerve palsy following thyroid surgery, so there's no point in giving it early on. But if we do feel that the nerve has been exposed, intraoperative steroids, they tend to reduce the postoperative temporary, they do not benefit in reducing the postoperative temporary or permanent palsy, but it reduces the recovery time suffering from temporary palsy. So that might be something which you might want to practice, might want to take home from this lecture. Coming to hemostasis, now this is where you're going to damage the nerve the most. Earlier on, we used to use a clamp and tie technique, used to take a long time. Bipolar cauteries came along. Then advanced bipolar cauteries like ligature came along. And nowadays, we tend to use something called as a harmonic scalpel, which is an ultrasonic device. Now, studies have clearly shown that the harmonic focus, this harmonic scalpel, is better in terms of reducing the operative time, hypocalcemia, hypoparathyroidism, all well for it, but they've not shown anything related to the nerve policies. Now, coming to basics about ultrasonic and bipolar devices, I always thought that the harmonic scalpel gets so hot. If you touch it, especially after using it, it's really, really hot and can burn your finger. And it might be the one which is causing damage. It's actually the other way around. The ultrasonic device works by mechanical action of the blade with conduction of heat away from the blade. So as a result, the tissue touching the blade is usually the same temperature as the blade. While in contrast, the bipolar device, the tissue surrounding the bipolar device can actually be hotter than the end effect itself. Now, bipolar cautery, I couldn't find a study which is done for thyroid surgeries, but somewhere around 70 degrees is what the temperature is for the surroundings. When we use a particular tip and settings around 10 to 15, for your bipolar, Valila bipolar. Irrigation does tend to reduce the spread. It's good to use the irrigation, and it's great to use a bipolar around the Berry's ligament, which is closest to the nerve. Now, harmonic versus ligature. Now, this tends to be used in the UK. I'm not really sure about the practices outside the UK, but if you're using these devices, we have to be careful about the lateral thermal damage and the thermal footprint. Even these devices have around 2 millimeters lateral thermal damage, so it is difficult to use these devices very close to the nerve, and they could lead to thermal damage to the nerve. Coming to the superior laryngeal nerve injury. Now, the incidence of superior nerve injury is around 0% to 20%. Now, this is really, really debatable. With permanent paralysis, around 0 to 5%. Visual inspection is often unrevealing. We tend to get something called as a rotation of the larynx to the contralateral cricothyroid muscle. Again, I have not seen many of these cases, or not diagnosed it that way. Acoustic analysis is something which you can use. It shows reduced frequency and range. And the cricothyroid muscle, we can do an EMG, which is obviously diagnostic for superior laryngeal nerve injury. Now, there are multiple classifications. We know Cernia's classification, but there is a classification by Kahner, Friedman, as well as Block. And it all depends on the relationship of the superior laryngeal nerve to the superior thyroid pedicle and where it turns into to supply the cricothyroid. There are certain precautions which you can take for your superior laryngeal nerve. You can reduce the traction in the superior pedicle, which avoids the stretching of the nerve and reduces the chances of paresis. Avoid mass clamping. You should always divide each and every vessel of the superior pole and use either ties or ligature clips or harmonic devices to make sure that you're not taking the nerve in your entire pedicle. Identifying the nerve and can use a monitor to confirm. Now, Cernia is one of the ones who has actually classified the level of the nerve. He has actually published about this, and identification of the nerve tends to give 0% superior laryngeal nerve paralysis. That's difficult to believe, but I think identifying the nerve and using the nerve monitor to confirm is a good technique to preserve the superior laryngeal nerve. Division of the sternothyroid to improve the exposure is something which you can practice to visualize the superior pedicle better. Now, to conclude my talk, mastering the anatomy, I did mention this before, and I think so this is the most important part. I haven't dwelt in the Bair's triangle, Joel's triangle. I believe everyone knows about them, and it's really, really important to have those numbers and have multiple variety of cases, complex cases and revision cases being done by you. So that increases the confidence with the nerve handling. Using magnification devices, I definitely would recommend using loops. It's a learning curve, but once you get beyond it, you really start reaping the benefits of it. Nerve monitors are there to help you. please use them. And the more you use them, the better you get at it. And be careful with powered devices around the nerve. I think so. It's important to understand that we do reduce the time which is required to required for the surgery, but around the nerve, it's very, you have to be very careful. And please audit your results and keep looking at the rate of paralysis. Keep looking at the rate of paralysis just to be sure. All right. Thank you so much.